We have no financial disclosures, and our funding mechanisms are as listed. In the 1940s, pelvic floor muscle training was developed to treat urinary incontinence in young postpartum women under the premise that improved skeletal muscle bulk and functional efficiency of the pelvic floor would improve urethral closure and bladder neck support, thereby decreasing urinary incontinence episodes. Currently, pelvic floor muscle training is an important component of the first-line therapy for urinary incontinence, regardless of age, based on data suggesting significant reductions in daily incontinence episodes. However, there is a lack of data exploring the efficacy of pelvic floor muscle training specifically to treat older women. Among older women, urinary incontinence may change from a focal pelvic floor condition into a multifactorial geriatric syndrome. Geriatric syndromes are defined as prevalent conditions present in older adults with shared risk factors such as impaired physical function and cognitive decline. Urinary incontinence and impaired physical function are interrelated geriatric conditions that result in part from skeletal muscle dysfunction. We hypothesized that the concomitant presence of urinary incontinence and physical function impairment may decrease the efficacy of pelvic floor muscle training. And the objective of this study was to prospectively examine the efficacy of pelvic floor muscle training in the presence of physical function impairment for the treatment of moderate to severe urinary incontinence in older women. We conducted a prospective cohort study of 70 community-dwelling women with at least moderate urinary incontinence symptoms based on the questionnaire for urinary incontinence diagnosis, or the QUID. Exclusion criteria are as listed. We used valid and reliable methods to assess outcomes. The short physical performance battery is a robust predictor for disability and includes assessment of balance, gait speed, and lower extremity strength. The presence of sarcopenia was primarily assessed using the appendicular lean muscle mass index gathered by the whole body DEXA. To test our hypotheses, physical function impairment at baseline was our primary predictor and was defined by having a short physical performance battery score of 9 or less. Scores above 9 define normal physical function. We estimated that a sample size of 60 women, or 30 per functional group, would provide 82% power to detect a decrease of 1 urinary incontinence episode per day. Next, we present our results. 253 women were phone screened between January 2018 and January 2020. 173 were ineligible, leaving 80 women who completed in-person baseline screening. 10 women screen failed, leaving 70 women included in our analysis. At baseline, 33 women had impaired physical function and 37 had normal physical function. The mean age was 76.9 years. For the entire cohort, there were no differences in mean age or race. 10-year survival based on the mean Charleston Comorbidity Index was approximately 50%. Depressive symptoms were uncommon, and mild cognitive impairment was present in many women. Women with impaired physical function had a higher BMI. When we examined baseline urinary incontinence symptoms, women with impaired physical function had significantly more urinary incontinence episodes, with urgency urinary incontinence being predominant. Bother from urinary incontinence symptoms did not differ by physical function group. When we examined markers of baseline skeletal muscle health, we found that women with impaired physical function had weaker pelvic floor muscle strength, had significantly lower appendicular lean muscle mass indices, and significantly weaker low extremities as indicated by the Biodex scores. At 6 weeks, we retained 85% of women with physical function impairment and 81% with normal physical function. After 6 weeks of pelvic floor muscle training, incontinent women with impaired physical function experienced a greater but non-significant decrease in urinary incontinence episodes, and a greater but non-significant increase in pelvic floor muscle strength from baseline. This difference was not statistically significant from women with normal physical function. After 12 weeks of pelvic floor muscle training, we retained 76 of women with baseline physical function impairments and 78% with normal physical function. Observations, however, in the change of urinary incontinence episode remain consistent. Next, we examined satisfaction and improvement rates. Overall, complete satisfaction with urinary incontinence improvement was low among both groups of women. However, women with normal physical function had 2.8 higher odds of rating their impression of improvement as better or much better compared to women with impaired physical function. Differences in estimates of improvement were significantly lower among women with impaired physical function compared to women with normal physical function. In conclusion, in this prospective study, the efficacy of pelvic floor muscle training, a primary recommended intervention for urinary incontinence, did not provide a significant reduction in urinary incontinence symptoms or improved satisfaction for older women with moderate to severe incontinence symptoms, regardless of baseline physical function status. However, older women with physical function impairments are able to improve their pelvic floor function to result in a modest improvement in urinary incontinence that was not observed among women with normal physical function. Our data strengthen the current observed associations between physical function impairments and urinary incontinence severity. When we consider future implications, our non-surgical approaches to treatment of urinary incontinence in older women should evolve to account for the likelihood of some women presenting with a novel phenotype of urinary incontinence named the geriatric incontinence syndrome that may feature more severe urinary incontinence symptoms and the concomitant presence of physical function and cognitive impairment. Thank you for your time.